Good afternoon. Welcome. I'm Sara Dash. I'm president and co-CEO of the Alliance for Health Reform. And for those of you not familiar with us, the Alliance is a nonpartisan, not-for-profit organization. We've been around for 25 years, and our mission is to inform policymakers and health policy leaders on the most pressing health policy issues and get you guys the foundations of health policy, the evidence, and the practice. And today we are here to talk about one of the most pressing health policy issues that has been making a lot of headlines recently, and that is the Medicaid program. Medicaid covers over 70 million people, as we will hear, and it is responsible for taking care of very, very diverse populations with an enormous range of medical needs, from healthy newborn babies to children with very special health care needs, to low-income adults, people with serious illness and disability, and more. And as we all know, recent legislation proposed, the American Health Care Act, would have made major changes to the Medicaid program, and certainly the discussion about the program is not over. So today's briefing is going to examine the relationship between Medicaid coverage, access to care, and health outcomes, as well as what might be next for Medicaid in the states, in Congress, and in the administration. And I'd like to thank first our sponsor for today's event, our partner, the Commonwealth Fund. We're very grateful for their support of this briefing. And before I introduce our panel, I just want to take care of a couple of housekeeping details. First, for those of you who need Wi-Fi credentials, they should be up on the screen. You can tweet to #FutureOfMedicaid. And when the time comes for questions, many of you know the drill, but write your question on a green question card or come to one of the mics on either side of the aisle, or tweet your question to #FutureOfMedicaid. So without further ado, I'm going to go ahead and introduce our panelists. We are still waiting on one panelist, but she will be joining us shortly. So our panel, to my left, is Sara Collins. She is Vice President for Healthcare Coverage and Access at the Commonwealth Fund. Gail Wilensky will join us. She is an economist and senior fellow at Project Hope. She directed the Medicare and Medicaid programs from 1990 to 1992 under George H.W. Bush. And all the way to the left there is Sara Rosenbaum. She is the Harold and Jane Hirsch Professor of Health Law and Policy and the founding chair of the Department of Health Policy at the George Washington University Milken Institute School of Public Health. So without further ado, I'm going to turn it over to Sara Collins, and we'll go ahead and get started. Thanks.
Thank you, Sara. Thank you, Sara, and good afternoon to everybody. And thank you to the Alliance and also the panelists for joining us today. As Sara mentioned, a major focus of the American Health Care Act was the Medicaid program, both the Medicaid expansion and also the traditional Medicaid program. The bill likely would have ended the Medicaid expansion over time, and it would have placed a federal funding cap on the traditional Medicaid program. In the wake of the failure of that bill, the question before us now on the panel and for all of you is what's next for Medicaid? To set us up for this discussion, I'm going to focus on the Medicaid expansion, refreshing our memories about where the states stand on their decisions to expand the program, and taking a look at the latest research on the effects of the expansion on coverage as well as other key indicators. As of today, 31 states and the District of Columbia have expanded eligibility for Medicaid. Of those, 6 have used 1115 demonstration waivers granted by HHS. These 6 states have struggled to reach political consensus on expansion and found agreement in alternative approaches, such as enrolling Medicaid beneficiaries in marketplace plans in the case of Arkansas, and imposing greater financial responsibilities on beneficiaries, including higher premiums and cost sharing. There are currently 4 states that are actively discussing expansion. The Kansas legislature has passed a bill to expand Medicaid. Although the governor has vetoed that bill, the legislature is attempting to override it. Governor Deal of Georgia has expressed interest in expanding Medicaid. In Maine, Medicaid expansion is a proposition on the November ballot this year. In Virginia, Governor McAuliffe has submitted a budget to the legislature that would expand Medicaid, with the Republican-controlled legislature considering it this week. Other states where expansion has previously been under discussion might be states to watch this year. They include Idaho, South Dakota, Tennessee, Utah, Wyoming, and a few other states. Based on Commonwealth Fund's latest scorecard, state scorecard, which we released in March, and numerous other federal and private surveys, it's pretty evident by now that with 3 full years of experience in the Medicaid expansion, that it's made a significant difference in coverage in states across the country. Uninsured rates have fallen in every state since the major coverage expansions of the Affordable Care Act went into effect, but they have fallen the furthest in states that have expanded Medicaid. There are 9 states that saw declines in their uninsured rates of 10 percentage points or more by 2015, and they were all in Medicaid expansion states. Kentucky had the largest decline, followed by California, New Mexico, and West Virginia. Since 2014, coverage gains have been the strongest among adults with lower incomes, and it's in this income range where the differences between Medicaid expansion and non-expansion states have been the most evident. Uninsured rates in expansion states among adults with incomes under 200% of poverty fell by 14 percentage points over 2013 to 2015, compared to 9 percentage points in non-expansion states. Coverage gains since the passage of the Affordable Care Act have been associated with gains in access to health care. But these gains in access, on average, have been greatest in states that expanded Medicaid. If you look at the middle bars in this chart, the share of low-income adults reporting that they had skipped health care because of costs fell by 5.5 percentage points between 2013 and 2015. In states that expanded Medicaid, compared to a decline of about half that in states that hadn't expanded their programs. Likewise, fewer adults across the country report that they don't have a regular doctor, but again, these declines have been the greatest in states that expanded their programs. So let's just consider the case of Kentucky and Tennessee. And I use this example because these are border states in the South with somewhat similar demographic profiles, but which took polar opposite approaches to their Medicaid expansions. Kentucky expanded their Medicaid program and also ran its own marketplace for a few years anyway, and also conducted an aggressive outreach campaign to encourage enrollment. Tennessee did not expand Medicaid and did not run their own marketplace. The states had similar uninsured rates prior to the Affordable Care Act. The uninsured rate in Kentucky among adults with low incomes fell by 25 percentage points. It fell by only 9 percentage points in Tennessee. Kentucky also experienced the largest decline in the country in cost-related problems getting care. The share of low-income adults who said they had gone without health care because of costs fell from 34% in 2013 to 21% in 2015. In contrast, Tennessee experienced no significant improvement on this measure. Likewise, many fewer adults in Kentucky reported in 2015 that they didn't have a regular source of care compared to 2013. And again, Tennessee did not see any measurable improvement in this measure. Ben Summers has been conducting a survey of low-income adults in 3 states since 2013 to track the effects of Medicaid expansion. He selected Arkansas and Kentucky, both of which expanded their programs, and Texas, which did not expand. His analyses have found significant improvements on key measures of healthcare use and self-reported health status in Arkansas and Kentucky relative to Texas. For example, compared to adults in Texas, adults in Arkansas and Kentucky had significant increases in getting checkups and significant decreases in visits to the emergency room. Ben also found that low-income adults in Arkansas and Kentucky experienced marked improvements in affordability, including a dramatic drop in annual out-of-pocket spending since 2013 compared to adults in Texas. One of the policy rationales for repealing the Medicaid expansion that we've heard a lot about is the contention that Medicaid provides inferior coverage compared to private insurance, and that having Medicaid is almost like being uninsured. But research hasn't really supported this claim. For example, this study that the Commonwealth Fund did using the Commonwealth Fund Biennial Health Insurance Survey found that Medicaid provided adults access to health care and financial protection that on most measures was comparable or better than that provided by private insurance and better than being uninsured. CBO estimates that by 2026, more than 70 million people will get their insurance coverage through Medicaid. As Sara said, that many get their coverage now through Medicaid, and 15 million of them through the Affordable Care Act's Medicaid expansion. This quick overview that I just went through suggests the value of this coverage in helping people get the health care they need, particularly large numbers of people with low incomes across the country. The program is really a cornerstone at this point in the U.S. health insurance system, and it really should be the concern of policymakers to ensure its strength and viability over time. In terms of what we might see in the next year in terms of Medicaid policy, some of the key questions are, will more states move forward on expansion? Will CMS grant greater flexibility for states through the 1115 waiver process, and what will be the implications of that for enrollees? Will Congress return to pursuing policies that would place state caps on federal funding of Medicaid, such as block grants or per capita caps? And if so, what are the potential implications for enrollees? And I'll stop there and turn this over to Sara.
Thank you. Thank you, Sara. So we may be nonpartisan, but we seem to have a bias towards people named Sara today. Gail Wilensky is here. While she's getting settled, let me just ask, for those of many of you obviously have been following the debate, but for those who maybe need a little bit of a refresher, can you just explain the difference between block grants and per capita caps? And I'll let Sara Rosenbaum chime in on that as well, so that'll help set the stage for the rest of the discussion. Thanks.
Good morning, everybody. Can you hear me? Yeah, okay. Good morning. So a block grant is a model of federal funding in which the federal government basically comes up with an aggregate cap on the federal contribution to state Medicaid programs. Many factors go into that aggregate cap. The Congressional Budget Office has very useful information on some of the factors that go into or could go into estimating an aggregate cap. The Commonwealth Fund has put out a short piece on how aggregate caps are built. But the point is it's an aggregate cap, and it doesn't necessarily relate to, and certainly over time probably would not relate to, actual population growth. A per capita cap is an approach to federal funding limits that would presumably tie to the number of people actually insured. So as the number of people goes up or goes down, the cap, the amount of funds would change. But as with an aggregate cap, a per capita cap also includes many factors that determine how it's going to grow going forward. So while a per capita cap might grow in relation to population, it's not necessarily the case that it would grow in relation to changes in service intensity, changes in the price of insurance or the price of health care, and other changes that would affect spending on a per-person basis.
Thank you so much. So I'm just going to give Gail a moment here to get settled again. Gail Wilensky, we're thrilled to have Gail with us. She, again, ran the Medicare and Medicaid programs under President George H.W. Bush and has many accomplishments besides that, and as do the other panelists, and I hope you'll check out their bios in the packets. So with that, we've heard an overview of the current state of play from Sara Collins, and I'll turn it over to Gail Wilensky. Thanks, Gail.
For those of you who don't know it, the Metro is shut down between Metro Center and Union Station, and we have opening of the ballpark, and so there are a gazillion people trying to drive around, but I'm delighted to have been able to join you. Fortunately, I had seen Sarah Collins' PowerPoint, so I know the points that she was making. I have a couple of observations that I wanted to share with you. The first is that it is important to acknowledge that Medicaid has been the ACA's clear success story, and I don't think we can ignore what we've been able to see. The Medicaid expansion actually accounts for the majority of newly insured. It has been able to do this without experiencing the kind of churn that we have seen in the exchanges. But on the somewhat negative side, the spending is running much higher on a per person level than was predicted. The second year, as expected, tends to be lower per capita spending than the first year somebody is on. Even so, it is way above what the expectations were. So that's one observation point. The second, and this is something not actually related to the ACA, other than in a very peripheral way, the Medicaid current match structure really makes very little sense for anything other than to start a program. What you have with the ACA expansion is the highest match rate covering the higher income of the poor, low-income population. It started, as you all know, at 100%. It's in the process of walking itself down to 90%. Even so, that is way beyond the matching rate that exists for the base Medicaid population, which, as you know, is between 50 and 73%. It not only doesn't make any sense to have different match rates for different parts of Medicaid. CHIP, of course, falls into this as well. But this seems to really have it backwards. You would think the federal government ought to pay a larger share for the poorest of the poor and not for those that are near the cutoff in terms of Medicaid expansion. We understand why that happened, to try to lure as many states in as possible. But once we are on any kind of stable footing, that needs to be resolved. We need to find a match rate, probably somewhere between the base match rate and the new match rate, and have it apply for the entire Medicaid program. Having these three different match rates for different pieces of Medicaid CHIP makes no logical sense whatsoever. The third issue that I want to raise is something that I have been commenting on now probably longer than I'd like to remember, but at least the last 25 years, which is that the states, we don't usually give them enough credit for creative financing and creative thinking, but the states have shown themselves very able to find various types of financing strategies, the end result of which is their part of the money is less than what is statutorily required. It has gone through various versions. The first started just before I was running Medicare and Medicaid around 1989, 1990 with something called voluntary donations. It's in some ways, because it was the most egregious, the easiest to explain and understand. For those of you who didn't recall, this activity started in West Virginia, and basically what happened was the hospitals would put up the state share of the matching rate by donating money, that's the voluntary donation part, to the state. The state would then use that money as its match money for the federal government. It would get the federal match, and the money would then go back to the hospitals, including their piece, which meant that basically the only new money in the system was that came from the federal government. There are various other strategies that eventually was sufficiently egregious that it was shut down. But provider taxes frequently function in basically the same way. Tax gets put on a group of the either physicians or hospitals. That money is part of what is used for the match. The match comes in, the matched money and the base money goes back to the source, either in its entirety or in large part. There have been more sophisticated ways which make it harder sometimes to shut down, involving intergovernmental revenue sharing, since that is a legitimate activity between the state and the counties, or the state and the city. That's harder to get rid of. Also, not having an upper payment limit that bears any relationship to cost has allowed states to do this. The upshot, this has been true as late as an OIG report that came out in 2016 for 2014, right before the match started, is that what we've assumed was the major constraint, that is the state's share of the match, isn't really doing the job in the structure that it was intended to do. One could question if the match was as small as 25%, whether it would have anyway for the poorest of the states. But it is just not a structure that continues to make sense. As an economist, a public finance economist, I was actually always taught matching grants are a good structure to follow because it gets contributions from the person receiving the money and is a way to try to have a maintenance of effort. Good in theory, this has proven not so good in actual practice, which is why I would like people not to be so dismissive of the notion of a per capita block grant. It fundamentally depends on the baseline that you use, the starting point, which is at the moment a bit awkward in the sense that 31 states, mostly blue states, have expanded. The other states have not, mostly red states. Kansas is trying, governor vetoed it. North Carolina and Georgia are thinking about it. But we need to find what is a rational starting point. And then we need to have a reasonable index to use, something maybe not quite as high as CPI-M, the medical component, but definitely higher than the regular CPI, maybe somewhere at least to start at CPI-M and then walk down a little bit as the exchange subsidies really want to do. If we were going to do something like that and throw in the requirement of a few outcome metrics, 5 or 6, we could have a very rational program. If you look at a Medicaid per capita block grant as a way of providing large amounts of revenue saving, then what I've just said really doesn't hold.
Thank you, Gail. I'll turn to Sara Rosenbaum now.
Thank you very much. So I think we've sort of heard a couple of things now. One is of course, from Sarah Collins. Has Medicaid worked and does it work? And the answer is yes. I mean, whether you measure it in terms of coverage, and of course Gail echoes the same point, or whether you measure it in terms of access to care, Medicaid appears to do just what we want insurance to do. And the second point, which is the one that Gail's raising, is what should the financial partnership in Medicaid look like? What are ways to allow the program to do what it's supposed to do while maintaining some sort of control over program size and growth? And the third is, which sort of flows from the second point, is if the financial partnership is going to change, how do we change, or do we change some of the structural aspects of the Medicaid program? I think it is absolutely imperative that we find answers to these questions. I first encountered the Medicaid program as a 24-year-old legal services lawyer in 1975 or thereabouts in rural Vermont, and have spent 42 years just extraordinarily moved really by what this program can do and what it means to people. And I think that this is not a program that we want to see live in a world of terrible uncertainty. It's a program that we should really spend some time reaching consensus on, careful consensus. Its size tells us we need to do that. It's 71 million people and counting. It is the least costly way to insure people. Its costs are appreciably lower than buying into commercial insurance in the private market, assuming that you're going to buy coverage that does not leave people with breathtaking deductibles and cost sharing. And it's clearly a program that is able to achieve a mission. And I think despite arguments to the contrary, it's very hard to sort of overcome the kind of evidence that Sara presented and that other studies have shown. The complexity in Medicaid is reaching some sort of new stasis. And that's because Medicaid, as far as I can see, plays 5 basic roles in the nation's health system. And there really is no substitute for this program. Medicare doesn't perform like Medicaid. You know, small discretionary grant programs clearly don't perform like Medicaid, and commercial insurance can't perform like Medicaid. It's not built to carry the kind of burdens that Medicaid carries. The first mission, or the first role, of course, is the one that really was brought into focus by the Affordable Care Act, and that is Medicaid as an insurance system for the working population and their families. The normal mechanism by which Medicaid achieves that level of coverage, of course, is through enrollment in managed care plans, and I actually suspect, I'm not sure, that sort of the initial bump up, substantial bump up, was because states and plans had a tough time, just like in the commercial insurance market, in figuring out exactly where and how to set rates for a newly insured population that included a lot of young, healthy people, young, healthy workers, but also older, sicker people entitled to alternative benefit coverage. Second, the program is really, and you know, part of it is that I'm at a school of public health, and so I think about this, but Medicaid is a central strategy at this point for dealing with the highest priority issues in population health, whether that's infant mortality and maternal mortality, whether it's services for children with developmental disabilities who need to be able to be integrated into school and community settings, whether it's long-term services and supports for people with chronic conditions, whether it's the opioid epidemic. Medicaid is really, in many ways, the most flexible means we have for dealing with population health priorities, and it has played that role now in the eyes of Congress and a series of administrations for decades. It, of course, is a partner to Medicare. I think it's the thing that many people forget about, but it really makes the Medicare program work for lower-income Medicare beneficiaries. It is a first health responder in times of crisis, whether it's naturally occurring crises or man-made crises. It is a program that has been there to insure people in terrible times, and it's capable of handling surges. And finally, Medicaid, and I think this is something that we had to go through the expansion for in order to fully understand, particularly in the expansion states. It is the financing system that anchors health system delivery reform in medically underserved communities. We have 65 million people living in medically underserved communities, and Medicaid is the primary insurer. And so it plays sort of this ecological role. And therefore, when you're doing Medicaid reform, you have to think of all of these issues. And even if you just wanted to pick one issue, you have to think about the spillover effects in other areas. So it is a very difficult program to sort of get your mind around, and any sort of reform effort has to be put into these contexts. There are 2 big areas, obviously, now that I think most of us who spend a lot of time with Medicaid are watching. One, as Sara Collins mentioned, is this issue of the 19 remaining expansion states. Will they, in fact, come in for the expansion? Will they come in as straight-up expansion states? They have the option to simply adopt the expansion, or will they potentially come in for expansion under certain circumstances? That is under 1115 authority, which I'm sure we'll talk more about. And some of the conditions being talked about are the ones that might be applied through 1115 are ties to work requirements, premiums with a lockout period for non-payment, open enrollment periods in Medicaid as opposed to enrollment as the need arises system, an end to what we call retroactive eligibility, which is a longstanding part of the program, a slimmer benefit package, timelines for coverage. These are some of the issues that have bubbled up either from current demonstrations or from past requests that haven't been acted on yet. The other big issue that everybody's watching is this issue of sort of broader Medicaid reform. How do we want the Medicaid program to run? Some of the points that Gail raised, and this all-important issue that is of particular interest in the expansion states, which is new strategies for delivery reform. How do we use Medicaid and the broader Medicaid coverage to shape delivery of care? How do we get greater efficiency in care? How do we integrate mental health and physical health care? How do we integrate health and social services more? And particularly this is the case for populations for whom Medicaid is a huge buyer, with really the ability to influence an entire sector of the healthcare system. We've known that this is the case for a long time in maternity and pediatrics. It is clearly the case for mental illness and addiction. It is clearly the case for long-term services and support. So these are the big areas of high-profile policy reform. So there are sort of two basic reform pathways in Medicaid, and we have three very different views going on right now about those two pathways to reform. One is the legislative pathway, and one is an administrative pathway because of the uniqueness of 1115 of the Social Security Act. And within the legislative pathway, over the past few weeks now, we've seen two competing visions. One is a quick strike system that takes a lot of money out of Medicaid, close to $1 trillion, and basically uses potentially a follow-on administrative structure, potentially follow-on legislative reforms to rebuild the program. So all the financing changes and none of the structural changes. And then we have the strategy that actually four governors in a very interesting letter to House and Senate leadership sent. And their vision is a vision that sort of turns the first vision on its head, which is very careful introduction of the kinds of financing reforms that Gail mentioned, with also a clear choice on the part of states to remain in a current financing structure, but with some limits. But allowing states also to move into more aggressive financing reform, coupled with very sweeping legislative, with structural changes in the program on basically all aspects of the program. And so we see these two very strong competitors for a reform vision. Finally, there is the question of 1115, which obviously can work by itself, or it can work in connection with some of these other reform efforts. And I will close here by saying that I think, quite frankly, 1115 has been way overblown. 1115 is a 1962 demonstration authority. It was enacted in order to create authority in the Secretary of then HEW, now HHS, to introduce important changes, test those changes, evaluate those changes, and determine whether certain changes are such that Congress ought to consider building them into the statute. Now, in fact, we've used 1115 quite well. One, actually, were a series of demonstrations begun actually a long time ago, broadened under the Clinton administration and carried over by the Bush administration to think about essentially giving Medicaid to people based on income, whether it was a slimmed-down package or a broader package, using income as the test. The two other big areas in which 1115 was used, tested, evaluated, were long-term services and supports, where 1115 played a crucial role in essentially restructuring the Medicaid statute ultimately to give states a lot more leeway and enable beneficiaries to live in community settings. And finally, managed care. The Balanced Budget Act amendments of 1997, the managed care changes that were quite sweeping, built on many years of testing managed care for Medicaid beneficiaries. First allowing some smaller changes, then allowing states to do demonstrations with larger compulsory managed care reforms, and finally introducing a new series of state options. 1115 is not an authority in the Secretary to make wholesale changes in the statute, in the Medicaid statute. 1115 is a pilot and testing system. And the question now is, where do we want to see pilots? Where do we want to see tests? What kinds of evaluation should we expect as a policy matter before an idea goes forward on a massive scale? And at what point is it proper and appropriate for states and the federal government, Congress, to expect that, in fact, certain kinds of issues will come up in the legislative arena as opposed to piloting and demonstrations? So why don't I stop there?
Like 14 years for Arizona?
Well, there is the question of whether certain, and this is an issue, whether certain long-term sanction demonstrations finally get a legislative sanction to go forward. But that was one state, now having proven its mettle.
Great, thank you so much. So we're actually at the question and answer portion of the briefing. So while you all want to think about your questions, you can stand at the mics, you can fill out a green card, and somebody will come around and pick it up, and then we'll try to answer it, or you can tweet to #Future of Medicaid. But while you all are getting organized, let me kick it off with a question. So, I mean, we've heard about successes of Medicaid, particularly with respect to, in this briefing, expanding coverage under the Affordable Care Act. We've also heard about some challenges, some cost challenges, some distortions in terms of how the federal match works. And so this is a huge program. So what is let me just ask each of you, what is the biggest problem we are trying to solve in terms of Medicaid reform, if you could, in your own words? What is the problem we're trying to solve? And then on the flip side, what is the biggest opportunity for the Medicaid program? And I'll let any of you kick that off.
I'm glad to start.
Thanks.
The problem that we're trying to solve is how to... The problem we're trying to solve is how to be sure the major source of coverage expansion under the ACA, Medicaid, goes forward on a rational, stabilized basis. I mean, that's generally the issue. And to assume that this one piece of Medicaid would continue along with CHIP at a 90% match rate, where the base Medicaid program is at a different one, doesn't make sense. And trying to integrate at whatever level the Congress is willing to support those various rates is one of the issues. I know that what Sara said in principle and in law is correct about the function of the 1115 waivers. I was teasing her about Arizona as an example. Arizona was the last state to come into Medicaid. By waiting so long, it decided that it should try to avoid some of the most common problems, which is having a lot of people show up either at the ER or without ambulatory support, and so they put in a modified structure to basically give people ambulatory choice opportunities. They stayed on their 1115 waiver until the Balanced Budget Act because the Congress didn't want to shut it down, and there was not a legislative vehicle handy. So yes, in principle, the 1115 process should be used to try out ideas, see how they work, and then legislation should move from that. Sometimes it happens, sometimes it doesn't. It's a very important function. If it obviously can be challenged in the courts, and on occasion it gets challenged as to whether it's beyond its bounds. The real opportunity I see is to think about Medicaid, the Medicaid population, and the population right above it, say to 200% of the poverty line or to 225% of the poverty line, as basically extensions of each other, and to try to make it easier to move money rather than people. One of the issues that Sara Rosenbaum and I have talked about over the last couple of years is the frustration that as you cross from 138% of the poverty line to 140% or 150%, you are basically forced to change your whole delivery system, which you may just have finally gotten to understand and to work, because many states seem to take pride in the fact that their people providing care under Medicaid were different from the people providing care in the exchanges. One of the options that has made sense to me is to basically let people use whatever subsidy money they're entitled to at that area of low income, and to either buy into Medicaid, which seems to have been able to handle the expansion better than many of the private plans. The ones that did seem to handle it better were basically companies like Centene and Molina that structured their plans to look very similar to their Medicaid managed care plans. And of course, I would give the option the other way as well. We need to think about this more as a continuum and have opportunities for people to move their money rather than to be forced into a different delivery system. That makes no sense. So I think that the observation that on a comparative basis, Medicaid seems to have handled the bulk of the expansion reasonably well. We don't want to force a disruption of that, but as a matter of fairness or appropriateness, I would let the option go both directions. I just don't think it would actually be used very often. But I also think that we're going to see a lot of use of both the 1115 waivers and the 1332 waivers that were built into the Affordable Care Act because they will provide the opportunity for many states to try things.
Thanks, Gail. Sara, would you like to comment?
I think that with Medicaid, the biggest problem we are trying to solve now, and it's actually, we've gone through sort of periods where this is the biggest problem in Medicaid, is less sort of specific and operational, although I certainly do agree with Gail that the financial structure of the program is paramount, and it becomes sort of part of the overall problem. But I think the problem that we are always trying to solve with Medicaid is aligning the dependence on the program and the role that the program plays with political views about the program. And by that I mean that Medicaid is part of the DNA of the healthcare system at this point. Its functions are so important, and unfortunately, a lot of those functions are not immediately visible to us and would disappear only if the program were really mortally injured in some way. I can remember a year back, 20 years ago, when the ability of all of the District of Columbia's children who need special education was imperiled. Their ability to start school on time was imperiled because of the billing and recovery mechanisms in DC Medicaid that had the city behind on recovering funds, and it was, so serious that when the school year began, the question was, would these children be able to go to school? So, these are the kinds of things that you understand if you understand Medicaid. You see that everybody's ability to live in communities, that the child welfare system, that the special ed system, that entire delivery systems all depend on Medicaid. And so we're at one of those moments right now where I think our biggest problem is this perception problem, this gulf between what Medicaid does in the world and at least some political viewpoints about Medicaid. So that's the problem. The opportunity in Medicaid is what I have always felt the opportunity was in Medicaid, which is that it represents the best handle we've got for addressing those aspects of population health needs that involve the healthcare system. Many population health needs do not involve the healthcare system. They involve other remedies that are not the subject of today's discussion. But when it comes to healthcare, Medicaid is the way in which we have chosen to finance healthcare for low-income people. And we've ended up making this decision for lots and lots of reasons. And I think in this struggle over how to reform Medicaid, we see, particularly in the governor's letter, a tremendous understanding of the importance of Medicaid to local health care delivery. It's a matter of reading and listening to states very carefully at this point, who are in the end the force for healthcare delivery, and shaping federal health policy to enable states to move more actively in sort of more holistic directions.
So I'll just jump in really quickly. A lot of people waiting to ask questions, but just to put a finer point on Sara and Gail's overviews of what's important. The political logjam in the 19 states that haven't expanded yet is really having an effect on overall measures of system performance in those states. And in our Commonwealth Fund state scorecard, we had 44 measures of health system performance, of which coverage, access to care, access to preventive care are part of that. And in the top, we do this every few years, and in the top quartile, every single state in that group has expanded their Medicaid programs. And this year, 3 states that hadn't expanded their Medicaid programs dropped out of that into a lower level, into the next lower quartile. So it's a program that exists as a key part of people's overall health systems in states. And so the getting through the politics and the political opposition to it is going to be really important to states' overall performance going forward.
Great, thank you all. So we have someone at the mic. We'll go to the mic, and then we have a lot of great questions on the cards.
Hi, my name is Carl Polzer. I'm a longtime health policy analyst, and I've worked for one of the speakers and alongside another, but I won't specify which ones, so they won't be embarrassed. My question is really, as this focus shifts from the legislative to the administrative on the work requirements and other types of requirements that states that are either re-upping their Medicaid expansions or proposing new ones, these seem to be the most controversial new requirements. Now, they may seem very attractive to a conservative economist, but I think there's some practical issues. So I'm being a bit facetious, but would it make sense to put employment offices, state employment offices in emergency rooms? I mean, people do have a lot of time to fill out forms and to take training there and decide what they want to do with their lives. Would you maybe also have a civil rights office there? Because people, when they go to work with illnesses, they might need protections. Like if they show up with hives or drip bags at McDonald's or other places, they might get jobs at that wage. And then they might need sick leave. Like most people at that wage don't get sick leave, and there's no legal requirement for it. So that would be actually an opportunity for a bipartisan agreement, so you could trade work requirements for sick leave. And then finally, I'm a consultant now, and I have cards. And I know there are a lot of nonprofit entrepreneurs in here and business guys and like lobbyists. So after the meeting, we can talk about the hospice population, because there's really great possibilities for temp work there, I think. I really think that some of them can really work quite effectively right up until the last minute. And you can save money on vesting on their pensions. But anyhow, not to be facetious, you need to think through the practicality of some of these requirements and just how deeply you could apply them. I'd just like some discussion on the work requirements.
Thanks. So, so we also have a question here about the work requirements, and I think let's dive into this for a second. This intersection between employment and Medicaid, and sometimes, you know, it's a little bit of a chicken or the egg. Either you're healthy so you can work, or you have to work so that you can get health insurance. So let's just talk about that. What can we expect to see out of the new administration? Is that going to come under the form of 1115 waivers? And what is the likely impact going to be?
I think it is likely to come through 1115 waivers. They've already indicated that. I was part, actually, so was Sara, of an interesting conversation a few days ago on this issue. And a couple of points were made that may be able to be helpful in the situation. The first issue is whether or not the people that are actually could work after you exclude all the obvious candidates, including pregnant women, people who have young children at home, et cetera, narrows down the group considerably. Childless adults who don't have major kinds of health problems, or people whose children are in school. The question is whether we would want, and the states would want, to cut off health care if someone doesn't do any of the options, which usually include training or education in addition to working. But another strategy that seemed to go after the same endpoint was the proportion of people likely to receive food stamps, and whether or not the work requirements in food stamps might be a better way to look at making sure there were strong work requirements, because the notion of cutting off someone's health care because for whatever reason they aren't following through on the work activity or efforts they're supposed to be doing seems not very likely. And the work requirement for food stamps may be able to have a much better handle on something that a state might actually consider. So I think that the spirit is understood of why this was raised. It is possible a slightly more sensible strategy to produce a similar outcome might be able to be developed.
So I want to get back to a point that was raised earlier about the connection between Medicaid and the health of the population, and Medicaid's role as a program in a very it serves many populations, but a very low-income population, medically underserved communities, and this idea of a wraparound between, you know, Medicaid, work, you know, transportation, those kinds of things. What can we expect? What has been happening in terms of Medicaid's role in this overall continuum of helping to improve people's health, and what can we expect to see going forward?
Well, first of all, I think it's important to note, and of course it goes to all of these issues, whether it's work requirements or time limits, or other conditions on eligibility, basically. One of the striking things about poverty in the United States is that while poverty is everywhere, we have many, many, many communities, urban and rural, where poverty is highly concentrated. And so in those communities, Medicaid becomes not only a means for purchasing health care, but it becomes an absolute staple of a local economy. It's able to support a healthcare economy that in turn supports other sectors in the economy. And it's also a program that supports certain kinds of entities, anchoring entities, whether it's a rural hospital, whether it's community health centers, a rural health clinic, that themselves offer an array of services. And so you have this interaction between Medicaid and local economies and local healthcare economies that makes the program a logical program for building out as an intervention. There's a very interesting report from the National Academy of Social Insurance that came out early this winter, looking at what states are trying to do to build new approaches to delivering health care to people who are enrolled in Medicaid that utilizes both certain kinds of healthcare providers and that expects healthcare providers to have formal affiliation agreements with other kinds of entities, including schools, including job creation programs, including social services. And so one way to think about getting at this dynamic from the earlier questioning is to maximize the opportunities that states have to think about healthcare delivery as part of a continuum of services that are targeted on communities that just are working with fewer resources. There are fewer jobs to have. And so if you look at what a rural hospital does in terms of its local economy, what a health center or rural clinic does in terms of its local economy, these are huge issues to factor in, along with the fact that you have the kind of anchoring healthcare in a local economy that then attracts other forms of commerce. So it's less than thinking about things like a work requirement as a condition of eligibility, having this sort of more sophisticated thought process about Medicaid as part of an economic engine system, I think would get us further.
Great, thank you. So we've had a couple of questions. I'm going to turn to the population that's covered under Medicaid, the long-term services and supports population. So we have a couple of questions about this. One question is that with 2/3 of Medicaid spending in states going to seniors and individuals with disabilities, an aging baby boomer population, and little stable private long-term care insurance to speak of, what is Medicaid's role in covering that population? And then a related question was, could somebody please expand on the influence of the per capita cap and block grant proposals on Medicaid services for people with disabilities?
I'm happy to start. One of Medicaid's greatest achievements. I mean, where you see the power of Medicaid compared to any other payer is what it is able to do for people whose disabilities are serious, whether they're young, whether they're working age, whether they're elderly, whether Medicaid is functioning as a companion to Medicare, whether Medicaid, we forget about one of the most interesting and important amendments, relatively small but significant, that Senator Grassley championed over a decade ago now, to make it possible for families with children with very serious disabilities to essentially buy Medicaid to complement employer coverage in order to get the benefit of home and community-based services that employer plans just don't cover. I mean, it's just not where employer coverage goes. I would be horrified and dumbstruck if most Medicaid spending didn't tip toward this population. These are the populations who really need a lot of health care. Most Medicaid beneficiaries are healthy, working-age adults or relatively healthy, and children, of course, who we hope are healthy. And so, like with any insurance, it's normal to think that Medicaid is going to skew in its spending toward high-cost, high-need people. That's the way insurance of any type works. In terms of federal funding limits, obviously, as Congress goes back to and thinks about introducing limits on funding, these will be the crucial questions, which is to make sure that funding limits don't spill over onto the costliest populations. For example, you know, a per capita cap is population sensitive but badly structured. It could also incentivize states to eliminate potentially a lot of optional eligibility groups that have their eligibility based on disability. But to the extent that per capita spending falls behind where it needs to be, a state may feel that it's just carrying too much financial exposure to maintain optional coverage for long-term services and support populations. So this is a crucial issue for the disability community. A block grant, of course, is even more problematic, or at least, you know, has problematic implications because of the concern on the part of states that if they're too overloaded, as they would see it, with people who have very, very high cost needs, their own financial exposure is huge. And this is obviously in a country where such an emphasis is now placed on high value on life and ensuring the best possible quality of life regardless of severe disability. This is probably the #1 issue we have to grapple with in Medicaid.
Some of the legislation has talked about having carve-out or different growth rates allowed for the aged disabled versus the non-aged disabled populations that are on Medicaid. And obviously that it's not a trivial issue, but recognizing that this is a different population with different needs. So I don't know how, we'll have to see what, if there's the next round, what it looks like in terms of that level of detail.
To something I thought I heard you say, Gail, and maybe you could clarify. You said that if there were a different financing structure that was different from the current FMAP, that we could have a more rational structure. But I believe what I heard you say is that if it comes with significant revenue cuts, or if it's seen as a vehicle for you know, significant cuts in funding, that is problematic. Can you talk about that? So, I mean, I guess what I'm trying to get at is, you know, why are per capita caps and block grants the answer, if you will, to some of the distortions you mentioned, like the higher FMAP for, you know, different populations, and the creative financing and so forth? And then, is there a way to address those issues without significant financial cuts to the program?
Well, let me go back to the basic point I tried to lead off with. The two big questions are the starting point and the growth rates. The starting point now, I think, will be very difficult to step back very far from where we are. Maybe some for the expanded population, but most of the bills that we've been talking about outside of the major ACA legislation, if you look at what the governors have talked about, or you look at Cassidy Collins, assume the start keeps most of the new money in. And the big question, and I think it is going to be hard for many members of Congress to try to claw back a lot of that expansion money. We saw a lot of the pushback that was coming on. The question is, how do you try to balance the states that have expanded from those that don't in terms of coming out with an acceptable starting point for the per capita block grant, and then how do you try to allow it to grow. The issue as to how you want to look at the distribution between what the state had been doing in setting up the block grant, the initial starting point, is one where you can take account, if you want, of various base income levels in the state. I mean, it's a very serious point about where do you start. It is understanding that once you do that, it becomes where is the growth rate. And of course, the reason that the per capita part, to my mind, is so critical as opposed to just a fixed block grant, is the state would be completely at risk for any kind of economic downturns or any kind of changes that affected the number of people who you would expect would be using this program. So I gather there seem to be some states that make noise like they just want the option to have a full block grant, but I don't understand why they would. That would seem to be a level of risk that no governor should want to take if they understand what it means in terms of going forward in a recession or following a major epidemic or something that would clearly impact the relative population.
Can we talk about accountability for just a second, and I'm going to get to the question at the mic. And we have a couple of questions on this. So this notion of flexibility and accountability, what are states accountable for right now under the Medicaid program, and what, if anything, should they be more accountable for?
Well, it's why when I've talked about not just dismissing a per capita block grant in Medicaid as without any merit, which I think is just not correct, I would, in exchange for the substantial increase in flexibility that provides, put on not an unreasonable number, but some 5, 6, 7 outcome metrics that states would have to report on relating to this population. And the reason it has bothered me greatly for a long time is that aside from various surveys that groups like the Commonwealth Fund or Robert Wood Johnson or other foundations sponsor, there is precious little information about what actually happens to the health outcomes of the population that is covered by the program. And for me, the quid pro quo would be substantially greater flexibility, substantially fewer occasions of mother may I kind of requirements coming in for waiver requests, and in exchange, some credible metrics about what happens to the population that's affected.
Yeah, if I could just add, I have to say from my perspective, I think actually states are accountable at this point for an extraordinary, really an extraordinary thing, and in some ways, the move to managed care has driven this point home, which is at one point when I first began to work in Medicaid, states were accountable for determining eligibility and getting a card to an eligible person if the person qualified, and obviously claims payment, so sort of a third-party claims payment structure. Today, much because of their own choices, they sought this power, and they have the power now, and they are using this power tremendously. States actually have taken on to themselves the responsibility for making sure that poor people get health care and medically vulnerable people get health care. Now, do we have the measures that we need to know whether they're getting the kind of value both in terms of health outcome and the terms of cost, in terms of quality? out of the arrangements they've developed that we would like? No. It's not, this is not my area of expertise, and my breath is constantly taken away when I'm sitting with people who do this kind of work. It's just how complicated it is to come up with these kinds of measures, and then the data systems to collect the information that would tell you what performance looks like. But I think that what we haven't embraced enough, at least here in Washington, is the tremendous responsibility that states have taken on that looks nothing like the responsibility looked 30 years ago. And the question always to me is less whether their responsibility is enough and more whether they need tools that they don't have at the moment to do a better job. The ability, the flexibility to use Medicaid financing to do certain things that are slightly off the beaten path for a commercial insurance plan. Frankly, I don't see the value in giving states more flexibility to take people off the Medicaid program. My tendency would be to think hard about where they need flexibility in order to be more effective and efficient in the delivery of health care itself.
Thanks. And we saw, and I just want to just point out in Sarah Collins' slides, we saw that in the states that did expand Medicaid, there were improvements in access to care and improvements in sort of measures of financial risk for the individuals. So I'm wondering if, Sarah, if you'd like to comment, or if any of the other panelists would like to comment on, and again, now we're back to talking about the expansion population, but what more is needed to help to get those numbers even better in terms of access to care and then health outcomes? And I want to link that too to something that really struck me in the state scorecard, which was that the state scorecard found that life expectancy or measures of premature death had increased in 2/3 of the states. And we've all kind of heard this. So, I mean, we're dealing with a population health crisis, it seems to me. How is this linked to the Medicaid program, and what tools do states need to make that link between Medicaid, having a Medicaid card, and improving access and improving outcomes?
So just a couple of comments on Ben Summers' work in Arkansas, Kentucky, and Texas. And he did look at a large number of access measures. So cost-related problems getting health care, medical bill problems, and one striking outcome on affordability was a 30% relative decline in out-of-pocket spending for people enrolled in the program relative to people in Texas. So major changes that stem from the protections in the Medicaid program that are actually very different from people who are buying coverage through the marketplaces in states that haven't expanded Medicaid, particularly on the out-of-pocket cost side and the premium spending side. But the other areas that are really important to look at in the work that he's done is the access to care among people with chronic health conditions, the testing of glucose testing for people with diabetes, and really importantly, the changes that he is finding in these states 3 years out on self-reported health status. So a significant decline in reports of being in fair or poor health in Arkansas and Kentucky relative to Texas. Now this is the self-reported health status is self-reported health status, but is actually, studies have found, highly indicative of mortality going in someone's life, so impending mortality. So these are not to be dismissed as measures that are not measures of health status, and trying to hold Medicaid to a higher standard than we even hold private insurance coverage to improvements in health status. Everyone goes back to the Oregon study, which of the Medicaid population, which was basically a randomized, ended up being a randomized study of enrollment in Medicaid and what effects it has on people's access to care, but also some small, some measures of health status as well. and not finding significant improvements in health status in that population. I think what one has to keep in mind when we're thinking about measures is to allow for a significant amount of time to go by before we can see actual impacts on health status. And I'll give you one quick example of a study done of Medicare beneficiaries who had been uninsured for most of their 50s and enrolling in Medicare at 65, and what their experience was after that. But there was a huge increase in utilization among this population once they got access to Medicare, and it took a good 7 years for that trend to flatten out, so it equaled utilization among people who were already enrolled in Medicare. And the people that benefited the most from that, from getting coverage at 65 in Medicare after having been uninsured, were people with serious chronic health problems, so heart disease. And those measures did change, but it took several years for those to change. So I think it's the caution in trying to look at health outcome measures in Medicaid is not to hold it to a much higher standard than we do other forms of insurance coverage, and that these access measures that we are seeing early evidence of really point to possible improvements in health status down the road.
I agree with that comment. I just think it's important for people not to claim more than, in fact, we know. The Oregon study was, to me, somewhat disappointing, that even in areas where you thought in the short term you would see some impact, like the hemoglobin testing or high blood pressure, the hypertension measurements, it's not obvious that you wouldn't see some impact in those areas. I don't have any problem with people saying we think it will take longer, but it would be much better to say that MEPS data, eventually will shed some light, because it at least has 2 years of coverage between the two samples and a lot more information about what's actually used. But we shouldn't make claims on the other side about what it's done. What we can see, which is hardly surprising given how much money gets spent, is that people and an ability to access in a way they didn't, and their out-of-pocket expenditures were less. It would be like, well, I should hope so. But will we see something on the effects on the health outcomes? It'll take more time, and don't make other claims which easily get made. That's not unreasonable. It just needs to be, if that's the position people want to take, it just ought to be sold as that and not something else.
Yeah, and I think also I completely agree, and I think also just thinking about what these measures might look like on health status, and is it a one-time decline or one-time drop in an outcome measure, or is it a flattening out of trend? So is it it's a tricky area to do analyses of the outcomes of insurance programs, and I think that thinking about what's a reasonable measure will take a lot of effort.
Great, thank you. Folks waiting at the mic very patiently. Go ahead and ask your question.
Thanks, Sarah. It's Mike Miller. I want to go back to something Sara Rosenbaum was talking about and drill down a little more within the essential providers, talk about rural hospitals specifically, because I know that's something that a lot of members are very concerned about. And if you and the others could talk about sort of the current situation with rural hospitals. In my experience, going back in some states the last few years, there's been an attrition where rural hospitals are slowly being forced to close or convert to non-inpatient facilities or things. Both what's the trend line projected, given the current status quo of everything going on, and how the different options for Medicaid could impact that, either continuing to enable the rural hospitals to survive or possibly the opposite. Thank you.
Thank you. Yeah, I think this issue of, access to care in rural America goes through these sort of wafting and waning periods of time. Certainly, a small part of the population lives in rural areas, but they are a very important part of the population. They have, right now, a lot of the kinds of health trends we're seeing in the data that Sara Collins alluded to are data that, you can't watch television now for 5 minutes without seeing reports about the declining life opportunities and life itself for people in poorer rural areas. It's in these areas, whether it's a hospital or a community clinic, that the loss of any capacity is critical. It, of course, has been a factor in the Medicaid expansion discussion now for years. In Kansas, where, of course, as Sara Collins mentioned, that both houses of the legislature voted to expand. Whether they will override the governor's veto is not yet known. But driving that decision was the crucial role that Medicaid plays in essentially the healthcare ecosystem. And it's why I feel so strongly that to understand Medicaid simply as the public equivalent of what, say, employment-based coverage does for those of us presumably in this room, is not to understand the Medicaid program because of the concentrated nature of poverty in the United States. Here in Washington, where there's, of course, relatively speaking, a high degree of affluence, we see the effects of concentrated affluence in healthcare and good coverage and good purchasing power because we have so many parts of the city with generous levels of health care. That comes from creating the economic circumstances that allow good health care systems to flourish. If you go to the poorest communities in the city, of course, you see the opposite, and that's equally true if you go to poor rural communities. And so getting to a point where people appreciate how sensitive health care itself is to Medicaid policy, I think is maybe the highest challenge we have. I was saying before to Sara Collins that we had done a study which ended up not coming out because of the demise of the American Health Care Act, but we were about to release a study that showed that had the Medicaid reductions of the level anticipated gone through in combination with the reductions in subsidized health care for people who were in the marketplace, along with an anticipated loss potentially of grant funding, 1 in 4 community health centers in the country was reporting to us a reduction of 5,000 patients or more. It was all over the country, but it was actually, of course, the health centers in the states that had expanded Medicaid, where they had been built up in both urban and rural areas. I mean, just unconscionable loss of primary care capacity. And that's really Medicaid talking at this point. And of course, it comes from Medicaid as an insurer, but it also comes from this phenomenon of Medicaid as a source of financing to stabilize health care.
Let me the politics of trying to come up with a rational resolution of the issues for rural health have been quite extraordinary during our political past. One of what I had thought was a very promising program started in the 1990s called the Each and Peach program of essential health facilities, and was an attempt to allow communities that couldn't afford their full-fledged hospital in that area to become something that they could support, which was a small holding center that would keep people temporarily either before they would get moved out to a rural referral center or they could go home. But it was a very limited number of beds and a very limited time they were supposed to hold them, which seemed like a really good transition type of structure. But then politics entered in, and everybody wanted one of these, and they wanted to increase the number of beds they could have, and they wanted to increase the amount of time they could keep them. And basically what had started as a really thoughtful way to try to make a conversion and the short-term holding and then move them out to someplace where you'd actually prefer that they get care that had any sophistication and complication attached to them. Similar kinds of events where if you make it the differential payment very attractive, you just see a bulldozer coming through to expand who can qualify for essential hospital status. It doesn't matter whether there's one that you can practically spit at nearby. Somehow those tend to get swept in. So, I mean, it is a problem that thoughtful decision-making ought to be able to help resolve, particularly in an age where you have so many ways to communicate and the kind of capacity telehealth could provide to people who are in very limited facility areas, or when they have more critical needs, to move them out to a place that is at like a rural referral center rather than where they are. But the ability to actually keep it focused and not just blow a hole so other groups that want the additional money that is usually attached stay out has eluded my observations of being able to happen. But I don't question the problems that you've described in some of the smallest and especially small, poor areas.
Thank you. So we are nearing the end of the briefing. And before I turn to the panelists for one last question, let me just remind you all you have a blue evaluation form in your packet. If you could fill that out before you leave, that would be fantastic. We really do want to hear your ideas for future topics that we should be focused on. So let me just ask each of our panelists to comment on perhaps a slightly provocative question, but just to end it on a broader note. So, you know, if you were talking to somebody right now who is a beneficiary of the Medicaid program, should they be optimistic going forward? What should we tell them about the future of the program as it currently stands with what we know right now, and what should they be looking to elected officials to do?
I actually have gotten this question. I do some volunteer work in my community with families who need the program, use the program, use subsidized insurance. And of course, I live in Virginia, so I'm sorry to say that I really haven't dealt with many adults who need the program or use the program. Typically, what I'm having to do is tell people they don't qualify for the program. But their children do. And I will tell you that the panic level was very high over the past month. It is really hard for those of us in this room, I think, to fully appreciate, unless, in fact, you have had, whether it's through patients or clients or volunteer work or family member or whatever, it's hard to overstate how important the program is to people and to the community providers that serve people. And what I found myself saying to people was, I don't think it will come to this. I don't think it will come to this. And that is why I said that I felt that the biggest problem the program faces today, and it's always been a problem with Medicaid, but it's particularly acute now, is the gulf between what this program means to people and the healthcare delivery system and what the political discussion looks like around the program. And it's why I continue to think that, along with Gail, with whom I've worked for over 30 years on this program, that the answer to Medicaid's future lies in sort of careful thinking through what you want this program to achieve, what tools we need to achieve it, and how to manage its costs. And those are the same questions we would ask about any insurance.
The expansion of Medicaid has played such a major role in expanding coverage to the previously uninsured. I find it hard to imagine in a political context, in a political environment, having that ripped away. But of course, it's easy for me to say that. My healthcare access isn't dependent on that. But we saw the kind of pushback from governors that expanded, from Republicans who were concerned about what this would mean, that along with the strong pressure from Democrats on the issue, seems very unlikely to occur. One of the very fortunate outcomes with the election is that we are closer to our usual position in the sense of having, especially in the Senate, a very closely divided Senate. That puts a brake on having ideas that aren't fully thought through with their implications, able to go very far or to do very much. They either have to satisfy the budget reconciliation rules, which are quite stringent, or they need bipartisan support, which is critical to not have a redo of what we've seen with the Affordable Care Act. It was truly astounding to me to look at what had been contemplated and hoped for, which is after 6 years of trashing the Affordable Care Act at every possible moment, Republicans looked like they wanted to recreate a similar political dynamic on their side. It's like, have you learned nothing about what it takes for stable legislation? No. I think that there are sufficient impacts that it will put a brake on doing bad things.
I think one of the most interesting aspects of what we've been through the last couple months is the focus on beneficiaries in the Medicaid who have enrolled in Medicaid expansion, and just hearing how much this coverage has meant to them. I know from our survey data, we have been hearing high rates of satisfaction with Medicaid among people who are enrolled who got coverage through the Medicaid expansion. 90% of people with Medicaid coverage are somewhat or very satisfied. And when you compare it to private coverage, so people who got plans through the marketplaces, more than half of Medicaid beneficiaries rated as say that they're extremely very satisfied with their coverage, and that's a much higher number than you see in marketplace plans. The other striking finding in the survey data that we continue to see we've seen for the last 3 years are people telling us who have Medicaid coverage that who have used their care, 70% saying they wouldn't have been able to get this care prior to enrolling in their plans. So I think that these numbers have been known for a while, but I think the debate over the American Health Care Act really brought those voices into the open, and maybe people not even realizing that they had Medicaid, that they had this new expanded coverage, and not totally not linking it to what it actually was. So I think just from policymakers' perspective, I think that the voices were heard pretty loudly in this debate. I think it did have an effect on what the ultimate outcome was, and I think going forward, the people who are enrolled in Medicaid are people that policymakers ought to be speaking to.
Well, please join me in thanking our panelists for a great discussion. Thanks again to the Commonwealth Fund, and please fill out your evaluations on the way out.